Good morning, friends. I'll be talking about acute liver failure, which is a very, very important issue, and the postgraduate and DNB and IDCCM students must know and should be able to answer in the examination everything about acute liver failure, including the indications for liver transplantation. The major resource document is the European Association for the Study of Liver. The guidelines have been taken from there in this lecture. So starting with the most basic thing, what is acute liver failure? Now, generally in layman's term, or when we generalize acute liver failure, it basically describes patients who present with or who are developing an acute episode of liver function. In hepatology, acute liver failure specifically refers to highly specific and rare syndrome, which is characterized by two very important things. One, there is initial severe acute liver injury manifesting as 2 to 3 times elevation of transaminases with impaired liver function, manifesting as jaundice and coagulopathy in a patient who has no previous chronic liver disease. The disease process is associated with development of a coagulopathy of liver etiology and clinically apparent level of consciousness due to hepatic encephalopathy, or altered level of consciousness due to hepatic encephalopathy. So this relation between jaundice and encephalopathy is a very important determinant when we decide whether it is acute, subacute, or hyperacute. So first sign is jaundice. Occurrence of hepatic encephalopathy is taken to define it. Like I said, hyperacute would be when hepatic encephalopathy occurs within 7 days of appearance of jaundice. Acute when hepatic encephalopathy occurs from 8 days to 28 days, that is within 4 weeks of jaundice. Subacute when it goes beyond 4 weeks, 5 to 12 weeks after jaundice. So these are the various classifications for acute liver failure. The most common that we use is O'Grady system that I just described. So within a week, it is hyperacute. Then 1 to 4 weeks, it's acute. Beyond 4 to 12 weeks, it is called subacute. And again, the marker everywhere is jaundice to encephalopathy. So that's very, very important. The other is the Japanese system, at the bottom of the screen, where they describe the acute as within a little more than a week, and then subsequently they call it subacute, and this they also call as fulminant. So it's not that fulminant and subfulminant terminology are completely out of vogue. They're still being used by the Japanese and also by the Bernau system, but the O'Grady system does not use the term fulminant or subfulminant. When we look at the causes, whether they are primary or secondary that lead to acute liver failure, primary causes which are pertaining to hepatic or primary acute liver failure, where emergency transplantation may be a treatment option if the medical management is not able to reverse the problem. It could be drug-related, acute viral hepatitis, toxin-related, Budd-Chiari syndrome, autoimmune, and could be pregnancy-related. Extrahepatic or secondary liver failure could be, in situations, but the emergency transplantation is not a treatment option, like in ischemic hepatitis following a severe episode of hypotension or cardiac arrest. In systemic diseases like hemophagocytic syndromes, metabolic disease, infiltrative disease, lymphomas, and infections like malaria. Then we have the chronic liver disease, which may present with a phenotype of acute liver failure, like a fulminant presentation of a case of Wilson's disease, autoimmune liver disease, a Budd-Chiari or Hep B virus reactivation, where transplant may be an option, or it could be liver resection for secondary deposits of primary liver cancer, alcoholic hepatitis, where emergency transplantation may not be a treatment option. When we look at the differential diagnosis, there could be malignant infiltration in the liver. So there could be history of cancer, massive hepatomegaly, elevated alkaline phosphatase, or other tumor markers. So, acute ischemic injury, transaminases are significantly increased, LDH is increased, creatinine is increased. There could be, hemodynamic instability, and patient may be having severe congestive heart failure, respiratory disease, or maybe in frank shock. Paracetamol, very high levels of aminotransferases and low levels of bilirubin, nearly normal levels of bilirubin. Rapidly progressive disease, there is acidosis and there is renal impairment, acute kidney injury. Low phosphate may be seen as a good prognostic marker, but replacement may be required. Non-paracetamol drug toxicity, subacute clinical course may mimic cirrhosis clinically and radiographically. Acute Budd-Chiari syndrome manifests as abdominal pain, ascites, hepatomegaly, and when we do liver ultrasound, there is loss of hepatic venous signal and portal vein may show reverse flow. Wilson's disease, it could be young patients with Coombs negative hemolytic anemia. Bilirubin to alkaline phosphatase ratio is very high. There could be Kayser-Fleischer rings and low serum uric acid levels, and the urinary copper could be markedly increased. Mushroom poisoning, severe GI symptoms after ingestion, and there is development of early acute kidney injury. Autoimmune may present as subacute, may have positive autoantibodies, globulin may be high, and characteristic lymphocyte patterns may be seen when compared to viral and other seronegative etiologies. Clinical course of acute liver failure, etiologies. Viral, you have hepatitis A, E, and B. As we know in India, E is very common. We will see that. So it's less frequent in association with CMV than herpes simplex or varicella zoster and dengue. Presentation may be acute. Drugs and toxins, paracetamol, acetaminophen, then the mushroom, Amanita phalloides, anti-tuberculosis chemotherapy, statins, NSAI, phenytoin, carbamazepine, ecstasy, flucloxacillin. Here, this could be acute or subacute. Vascular Budd-Chiari, it's acute or subacute. Hypoxic hepatitis, it is acute. Pregnancy, it could be either preeclamptic liver rupture, or it could be HELP syndrome, or it could be fatty liver, acute fatty liver of pregnancy, AFLP, where it is acute. Wilson's disease, autoimmune lymphoma, malignancy, HLH, it could be acute or subacute. Now, when you see the distribution, now this is showing worldwide distribution of the causes of acute liver failure. When you look at UK, now you see the majority of the acute liver failure is because of acetaminophen, paracetamol poisoning. This is 57%. And when you look at the viral etiologies, it is much, much less. When you just see another European country, Germany, you find again the acetaminophen is much less here. Other drugs are there. Then Hep B increase, and there is hepatitis A related also. Let's come to India. So when you come to India, you find that the paracetamol is nearly non-existent. It is basically hepatitis E, which is the largest component, then hepatitis B, then hepatitis A. So largely, hepatitis would be about 70%, and remaining would be others like unknown or other things. You go to Bangladesh, you find hepatitis E is about 75% and B is about 13%. Others, and hepatitis A is 3%. So largely because of hepatitis. So this is again showing the same data, epidemiological studies. So you can see when you look at India, paracetamol, the reported is 0. Compared to other non-paracetamol is also very, very less. And when you look at the viruses, it's quite high, and mainly majority are hepatitis E. So when you look at the common management issues and condition-specific care elements, for cardiovascular system, if there is hypotension, we need to monitor, invasive monitoring. Echocardiography is required to look at the right and the left heart. Intravascular volume, if it is depleted, then we have to go for volume correction. If patient is vasodilated, we may have to use vasopressors. Similarly, if it is a low cardiac output and right heart failure, we may need inotropic support. Pertaining to liver, if there is evolving hepatic dysfunction, we need to go for serial biochemistry and coagulation testing, and we may have to start the N-acetylcysteine IV. There is a risk of aspiration pneumonia, especially when the mentation is poor and hepatic encephalopathy is increasing. So we need to observe them. They need to be in the HDO or ICU environment, and early tracheal intubation if the depressed level of consciousness is there, the GCS is 8 or below. Other management issues are when there is hypoglycemia, which is not uncommon. Serial biochemical blood sugar monitoring has to be done, and we should aim to maintain normoglycemia. Hyponatremia, again, has to be managed. Renal dysfunction, lactic acidosis, hyperammonemia, we may have to go for renal replacement therapy here. Impaired drug metabolism, we have to review the drugs and look at liver-friendly drugs or modify the doses if the drugs have hepatic metabolism, but they are essential. Central nervous system, progressive encephalopathy, we need to monitor neurologically, look at the serum ammonia level. We may go for a transcranial Doppler, or we may, in some situations, go for intracranial pressure monitoring. Where the risk of bleeding is high, we'll talk about that. And we need to treat fever aggressively, hyponatremia. We need to screen these patients for sepsis. And if there is high-grade encephalopathy, then we need to go for endotracheal intubation, mechanical ventilation, and avoid severe hypocapnia or hypercapnia. Sodium target is 145 to 150, and also assess for intracranial hypertension. If there is intracranial hypertension, then we need to employ measures to reduce pressure surges like osmotherapy, where we can use mannitol or hypertonic saline, temperature control, and indomethacin and thiopentone would come as rescue therapies. Coagulation system, laboratory coagulation tested may be done. As you know, no correction is generally recommended because INR is an important marker that we'll be using to decide about feasibility of transplantation if the patient is not improving. So no routine correction. Correction should be done only when patient is bleeding or there is a need for invasive procedures. High risk of sepsis, clinical evaluation should be done, and antibiotic prophylaxis. So this basically more or less sums up. And when you look at the criteria for selection of patients with acute liver failure, now all three criteria, we'll talk about them in detail later. King's College criteria, Clichy criteria, and Japanese criteria include age, encephalopathy, and coagulopathy. These are common. So this is very, very important. That means encephalopathy, coagulopathy, and age would be in all these criteria. Now, this is from a New England Journal classic paper by Julia Wendon, which looks at the impact of acute liver failure. So in brain, it can cause hepatic encephalopathy, cerebral edema, intracranial hypertension. In lungs, it can cause acute lung injury, ARDS. It can cause high output state in the heart, and it can also cause subclinical myocardial injury. Then liver, it can cause, loss of metabolic function, and there could be decreased gluconeogenesis leading to hypoglycemia, decreased lactate clearance leading to lactic acidosis, decreased ammonia clearance leading to hyperammonemia, and decreased synthetic activity leading to coagulopathy. Pancreatitis may also be seen sometimes in association with acetaminophen related toxicity, and there could be inadequate glucocorticoid production contributing to hypotension. There could be bone marrow suppression, especially in viral disease, and kidney is oftentimes affected, so there could be AKI. The leukocyte function may be impaired, and there could be immunoparesis leading to high risk of sepsis. That is the rationale also that we need to give prophylactic antibiotics. Portal hypertension may be prominent in subacute disease, and there it may cause a confusion with the chronic liver disease. And there could be high energy expenditure, rate of catabolism, so nutrition would be important consideration here. Again, to summarize the same thing, we can see, it causes cerebral edema in the brain. It causes coagulation abnormalities, thrombocytopenia, causes infections, predisposes to bacterial, fungal pneumonias, aspiration pneumonias, hemodynamic hyperkinetic syndrome, arrhythmias could be there in lung, acute ARDS, pneumopathy, pulmonary overload, renal failure, and metabolic issues. Whole lot of issues could be there. So how do we diagnose? What tests should be sent? Diagnosis, of course, would be clinical as well as presence of transaminases, jaundice, encephalopathy. But normally we have to send the cultures also, as these acute liver failure are predisposed to infections. A routine X-ray, ECG, liver echo. In the ICU setting, you can go for a POCUS also, and then axial imaging of abdomen and chest may be required, cardiac an ECG. And routine monitoring would include the usual ICU monitoring as well as the neurological status monitoring. Standard care could be, glucose infusion. In fact, in standard neurological, initially, when you have to look at the brain edema, you can also go for optic nerve sheath diameter. Standard care, glucose infusions with a glycemic target of 140, around 140, sodium target 135 to 145, stress ulcer prophylaxis, restrict clotting factors until there is active bleeding, NAC in early stages, even in non-PCM cases. Preventive measures, avoid sedatives, avoid hepatotoxic, nephrotoxic drugs. Propofol may be a good choice if you have to sedate these patients. If there is hepatic encephalopathy, you need to transfer to an appropriate level of care facility. Maintain quiet surroundings, elevate head of bed 30 degrees, keep head in neutral position. These patients should be intubated, ventilated, and sedated if they progress to more than 3 hepatic encephalopathy grade 3. Start empiric antibiotics if they are hemodynamically also unstable, or if encephalopathy is increasing, because this generally goes with the inflammatory phenotype here. And if intubate, sedate prior to transfer to another higher center, and ensure that volume is repleted adequately, and try to normalize the biochemical variables. Suggested criteria: when should a small hospital refer it to a liver center where transplant facility is available? For paracetamol and hyperacute etiologies, arterial pH less than 7.3, bicarb less than 18, or INR more than 3 on day 2 or more than 4 thereafter, oliguria, raised creatinine, hepatic encephalopathy, hypoglycemia, unresponsive high levels of lactate despite fluid resuscitation. In non-paracetamol, pH again less than 7.3, bicarb less than 18, INR more than 1.8, oliguria or AKI or sodium less than 130, encephalopathy, hypoglycemia, metabolic acidosis, serum bilirubin more than 17.6 milligram per dl, or shrinking liver size. So do not hold the patient if you do not have liver transplantation facility. Shift the intubate and safely transfer the patient to a liver center. Now, when we look at the guidelines in terms of how should we go for fluid management, so crystalloid volume resuscitation is recommended, and it should be guided by appropriate monitoring techniques. Norepinephrine, if required, is the vasopressor of choice, and do not overload, do volume overload. Hypoxic hepatitis may require consideration for inotropic agents. Blood pressure target has not been defined, but I would suggest, keep it above 65 millimeter mercury, the mean arterial pressure. Hydrocortisone does not reduce mortality, does decrease vasopressor requirements. So as part of the sepsis, you may still use it if the patient continues to be in refractory shock. Per se, for liver failure, it has no impact. Standard sedation, lung protective ventilatory techniques should be utilized. Avoid excessive hyper or hypocarbia. Regular physiotherapy should be done. VAP should be avoided. Resting energy expenditure is high, so start enteral or parenteral nutrition early. Avoid nasogastric feeding where patient is not intubated and there is progressive encephalopathy. Monitor ammonia whenever you are starting enteral nutrition. PPI administration should be balanced against risk of VAP and C. diff infection. So if enteral feeding has been established, then you may stop using PPIs. Look at the biochemical abnormalities carefully and try to normalize them. Hypoglycemia needs to be corrected, but at the same time, avoid hyperglycemia. Hyponatremia is detrimental to the outcome, so it should be maintained around 140 to 150 millimoles per liter. Lactate may be related to increased production and decreased clearance. It continues to remain a poor prognostic marker. And generally, when we have both a combination of metabolic acidosis and high lactate and AKI, RRT may be a suitable tool to use here. Renal failure, early institution of RRT, this will help us in controlling the ammonia levels, sodium level, and also maintaining fluid balance. And we can do temperature control also with the new machines. Anticoagulation remains a matter of debate, and close monitoring of metabolic status should be undertaken. Normally, we don't use citrate in acute liver failure situations, so go with conventional unfractionated heparin if required. Continuous RRT is better if the patient is, in acute liver failure as opposed to intermittent, because intermittent is found to increase the intracranial pressure because there could already be a raised intracranial pressure. So CRRT is better. Blood products, routine use of fresh frozen plasma, coagulation factor is not supported. Should be limited to issues like insertion of ICP monitor when there is active bleeding. Hemoglobin target remains same, restrictive 7 gram per DL. Venous thromboprophylaxis can be considered every day when you are reviewing the patient. Prophylactic antibiotic, non-absorbable antibiotics, antifungals have not shown to improve survival. Regular periodic surveillance culture should be done. Early anti-infection should be introduced when there is hepatic encephalopathy. So one single marker of deterioration is hepatic encephalopathy. And if there is clinical overt signs of infection or elements of SIRS like tachycardia, tachypnea, appearance of band cells, then changes in the patient is hypocapnic. Antifungal therapy can be used if patient is in ICU for a longer period of time and there is multi-organ failure. These days we can use biomarkers like the beta-G, beta-D glucan, as well as the serum galactomannan test. When there is hepatic encephalopathy, what do we need to do? We need to monitor them, so they have to be in a protective environment. Grade 3, grade 4 require intubation, taking precautions that the ICP is not raised during intubation. And like I said, initially we can see if the optic nerve sheath diameter is increased, that tells us about the brain edema, but subsequently it's not a very good monitoring tool. So transcranial Doppler is proposed, is a useful non-invasive monitoring tool to see the brain edema and monitor its progress. Intracranial pressure monitoring, I've never seen my colleagues do it for the fear of bleeding, although people do it sometimes when it is required under cover of recombinant factor 7A. Generally, the indications would be younger patient with hyperacute or acute presentation. Ammonia levels are beyond 150 to 200 micromole per liter and are not reducing, or patient continues to be on vasopressor support. So, and mannitol hypertonic saline can be introduced, administered for intracranial pressure surges. Hyperventilation may be an extreme tool and is not routinely recommended. So, regarding liver support systems, 20 years back, the liver support systems, the MARS, etc., were in vogue. Now we know that biological or adsorbent systems have not shown any clinical benefit, so they can be used only in context of a randomized controlled trial. Plasma exchange in randomized controlled trials have shown to improve transplant-free survival in these patients and to modulate the immune dysfunction. So evidence is level 1, grade of recommendation is level 1. Plasma exchange may be of maximum benefit in patients who are treated early and who will not ultimately undergo liver transplantation. Level of evidence is 1, recommendation is 2. Prognostic assessment should be done at the site of first presentation and then at the transplant center or the liver center. Development of encephalopathy is a key prognostic importance, indicating increasing criticality. Prognosis is worse in patients with more severe liver injury, extrahepatic organ failure, and subacute presentation. Transplantation should be considered in those patients fulfilling Clichy or King's College criteria. So what are these criteria? King's College criteria are when it is due to acetaminophen or paracetamol, arterial pH less than 7.3 after resuscitation, and more than 24 hours after ingestion, lactate more than 3 millimoles per liter, or 3 of the following criteria. That is, hepatic encephalopathy more than grade 3, serum creatinine more than 300 micromole per liter, INR more than 6.5. Non-paracetamol acute liver failure, INR more than 6.5, or 3 out of the 5 criteria. Etiology is indeterminate hepatitis or drug-induced, age less than 10 years or more than 40 years. Interval between jaundice to encephalopathy is more than 7 days. Bilirubin is more than 300 micromole per liter, and INR is more than 3.5. Clichy criteria look at 3 things: confusion or coma, that indicates hepatic encephalopathy 3 or 4. Factor 5 less than 20% of normal if age is less than 30 years, or less than 30% if age is more than 30 years. When you look at these criteria, whatever criteria are being used globally, so you can see that the King's College criteria has very good sensitivity and it is highly specific, 92%. Clichy, other criteria, for example, the MELD criteria, which is model for end-stage liver disease, are not as sensitive. 76% is the sensitivity, which is more than the King's College, but the specificity is much less. So depending on what your center is choosing, these are what things are globally used. So once again, the Clichy criteria you can see, and this is how you calculate the MELD score. 3.78 into serum bilirubin into 11.2 into INR into 9.7 serum creatinine plus 6.43. When you interpretation is important. So if the score is 40 or more, the mortality, 3-month mortality is 71.3% or more. 30 to 39, 52.6%, 20 to 29, 19.6%, less than 9, 1.9% mortality. So this is a score that the liver people or hepatologists use quite often. This slide I'm showing you again. Now, 3 things, like I said, age, encephalopathy, coagulation are there in all the systems as a requirement for transplantation. Now, when we look at the assessment and management of acute liver failure, We need to rule out any pre-existing cirrhosis and chronic liver disease or alcohol-induced lung injury. Radiology can sometimes in these situations mimic cirrhosis. There is loss of hepatic mass, regenerative nodules, etc. If required, liver biopsy may be used through transjugular route to exclude cirrhosis. Always search for an etiology here. And when transplant is not feasible, malignant infiltration of liver can be ruled out either by imaging or by biopsy. Ischemic injury is generally hypoxic and it may recover gradually. Then HLH may be precipitated by viral fungal infections or may be seen in hematological malignancies. The role of liver transplant is unclear when there is poisoning because of liver poisoning because of mitochondrial toxins like yellow phosphorus. Diagnosis, like I said, depends on acuteness and encephalopathy. Viral serology is to be done, autoimmune serology is to be done. And when you are suspecting Wilson's disease, do not wait for ceruloplasmin levels or copper levels. You can look at the bilirubin alkaline phosphatase ratio. If it is more than 2, it is indicative. Very high aminotransferase levels and low bilirubin levels should alarm you to the presence of acetaminophen overdose or ischemic liver injury. Have a low threshold for liver biopsy. Serum ammonia levels, if the levels are below 75 micromole, then it is ICH is rare. Intracranial hypertension is rare. So if serum ammonia is more than 100 on admission, this is an independent risk factor for development of higher grade of hepatic encephalopathy. Serum ammonia more than 200 predicts intracranial hypertension, and risk of developing intracranial hypertension can be reduced if we maintain sodium between 145 to 155. How do we manage intracranial hypertension? Well, use osmotic diuretics, keep MAP more than 75 millimeter mercury, cerebral perfusion pressure between 60 to 80 millimeter mercury. Vasopressin can be safely used as an adjunct to noradrenaline. If ICH does not respond to usual osmotic diuretics, then therapeutic hypothermia can be used. However, there is a concern. Some liver surgeons don't like it because there is a concern for impairing, it may impair with liver regeneration. Concern about bleeding from neurological monitoring is there. Like I said, people who are going for ICP monitoring, they may be using recombinant factor 7A, but then risk of thrombotic complications also increase. These are the grades of encephalopathy that you can see. So grade 1 is there is change in behavior, but minimal change in level of consciousness. That means patient is talking irrelevant things, but is fully conscious awake. Grade 2 is gross disorientation. Patient is drowsy and inappropriate behavior is there, maybe, hurling abuses, etc. Grade 3, there's marked confusion. His speech is incoherent. He's sleeping most of the time, but may still be arousable to vocal stimuli. Grade 4 is comatose, where he's unresponsive to pain, or there could be decorticate or decerebrate posturing also present. So, just to repeat, in grade 1 to encephalopathy, we need to look at transfer to liver transplant facility and listing for transplantation. Do a brain CT to rule out any other cause of decreased mental status. Avoid stimulation, avoid sedation if possible. Antibiotic surveillance and treatment of infection is required. Prophylaxis possibly helpful and lactulose possibly helpful. Grade 3-4 encephalopathy, we need to continue all the above measures. In addition, intubate the trachea, elevate the head of the bed, consider placement of ICP monitoring if that is the norm in your unit. Immediate treatment of seizures is required. Prophylaxis have unclear value. Mannitol may be used when the ICP is severely elevated or there is first clinical sign of herniation appears. Hypertonic saline can be used to raise sodium to 145 to 155 millimoles per liter. And hyperventilation has very short-lived thing. So it has to be used only when there is, as an emergency measure for impending herniation. For infection, surveillance and prompt antimicrobial treatment of infection is required. Antibiotic prophylaxis, although most of the time given, but has not been proven. Coagulopathy, vitamin K, give at least 1 dose. FFP give only for invasive procedures or active bleeding. Platelets only for invasive procedures or active bleeding. Recombinant factor 7A possibly for invasive procedures. Prophylaxis for stress ulcer, H2 blockers or PPI. Renal failure, hemodynamic upset, go for volume replacement if required, go for pressure support, avoid nephrotoxic drugs. Continuous mode of hemodialysis is preferred. Vasopressin is recommended if hypertension, which is refractory to volume resuscitation, and epinephrine is not available. Norepinephrine is not available. Monitor glucose, potassium, magnesium, phosphate, try to normalize them, maintain euglycemia, early enteral feeding if it is possible, or use of TPN because it's a catabolic state. Liver transplantation, if nothing else is helping and patient fulfills the transplant criteria, the 1-year survival after cadaveric transplant is less than for chronic liver disease. So this we must communicate to the family. It is still difficult. MEL score has not improved our accuracy. The discriminatory power is not superior to INR-based criteria or King's College criteria. King's College criteria have been found to be the most useful, as we have seen. And we should also realize that there is no good evidence for artificial support systems. So who to admit? When there is clinical or lab evidence of acute hepatitis, if PT is more than 1.5, altered sensorium is there, it's very important that we admit these patients in the ICU because the deterioration may happen very fast and then there is a crisis. So admit the patient in the intensive care unit. Now specific etiologies. Acetaminophen, normally at least 4 grams is required. Intermittent intake generally doesn't cause poisoning. It's one-time large dose and commonly seen with doses more than 10 grams. Extreme elevation of transaminases to the tune of more than 10,000, and bilirubin remains generally normal. Very early presentation may show marked metabolic acidosis, increased lactate, and it may take time for transaminases to raise, and there could be initially minimal coagulopathy. So start fluid resuscitation, IV N-acetylcysteine therapy, plus minus CRRT. High levels may not be seen in stagger toxicity. SOFA is preferred to assess extent of organ injury, which we all use. And clinically, it may progress to a higher grade of hepatic encephalopathy or full-blown multi-organ failure. If do not meet transplant criteria, prognosis is good. If they meet transplant criteria, it's not so good because survival rate is 20 to 40% in good ICUs. Mechanism of paracetamol toxicity, we know acetaminophen is metabolized in the liver cells by cytochrome P450 enzymes to the toxic metabolite NAPQI, which is N-acetyl P-benzoquinonamine, NAPQI, that normally is detoxified by conjugation with glutathione. So in people like you and me, where we assume the liver is normal, any NAPQI will be conjugated by glutathione and detoxified. Now, what happens when there is accelerated liver injury? There is depletion of glutathione and there is reduced detoxification of NAPQI. So that is the problem, which is accelerates the liver injury. NAC, when given, is good because it replenishes the glutathione stores. Acetaminophen-induced injuries concentrated in central zones of liver and portal tracts are mostly spared, except in extreme injuries. So spontaneous recovery may occur in about 80% of the patients with timely NAC therapy. Serum levels of acetaminophen in blood are proportional to the amount of acetaminophen ingested, and they may allow a stratification of risk, for liver failure if we do not know the time of ingestion. NAC, if patient comes within 4 hours, give activated charcoal before NAC. IV administration of NAC, 150 milligram per kg in 5% dextrose over 15 minutes is the loading dose, followed by 50 milligram per kg over 4 hours as maintenance dose, and then 100 milligram per kg over 16 hours or 6 milligram per kg per hour as the maintenance dose. When to stop is a big question, whether standard 72-hour period is optimal or we should continue until the liver transaminases come to acceptable levels. Non-acetaminophen poisoning, mushroom, drug-induced, etc., these we have discussed before. So what do we do with mushroom poisoning? Penicillin G, 300,000 to 1 million units per kg per day. Silibinin, 30 to 40 milligram per kg per day. And then NAC and transplantation. I do not have experience with mushroom poisoning. So I have experience with NAC and the transplantation. So when it comes to drug-induced acute liver failure, identify and withdraw offending drug, discontinue all but essential drugs, and use NAC. So NAC everywhere, standard. That's become the standard practice also across the Indian ICUs. Viral hepatitis would require supportive care. Lamivudine in hepatitis B-related acute liver failure and for prevention of post-transplant recurrence. If suspected herpes or varicella zoster, treat with acyclovir. Wilson's disease may require albumin dialysis, continuous hemofiltration, plasmapheresis, or plasma exchange to acutely decrease the copper levels, and consider transplantation if Wilson's is leading to acute liver failure. Autoimmune hepatitis, if autoantibodies are negative, we may have to go for liver biopsy. If coagulopathy and mild hepatic encephalopathy is present, we can give steroids, prednisone 40 to 60 milligram per day, and consider these patients for transplantation. Now, pregnant women, acute fatty liver of pregnancy, HELP syndrome, fast delivery of infant, and if it does not subside after delivery, transplant may be considered as an option. Acute ischemic, general ICU management, achieve hemodynamic stability, there is no indication for transplant here. Budd-Chiari, which is acute hepatic vein thrombosis, first by liver ultrasound, confirm the diagnosis, and consider for liver transplantation only if the underlying malignancy has been ruled out. If there is malignant infiltration, transplant is not indicated. Non-acetoamine acute liver failure may be difficult. This we have already discussed. I think we can skip this slide. And indications of poor prognosis. When there is idiosyncratic drug injury, acute hepatitis B, autoimmune hepatitis, mushroom poisoning, Wilson's disease, Budd-Chiari, indeterminate cause, a patient comes in grade 3, grade 4 coma, or is a transplant candidate. So coming to the end of the talk, acute liver failure is a life-threatening syndrome that involves nearly all organ systems. It should preferably be treated in tertiary care center where full spectrum of treatment, including liver transplantation, is available. So referral to liver center if the patient meets those criteria and he goes into encephalopathy fast. But before shifting, if intubation and ventilation is required, do that, stabilize the patient, and then shift. Early liver transplant for a patient with good prognostic indicators is associated with better survival, and management is always a team effort. Thank you very much. I hope you like the lecture, and I hope it clarifies some of the thoughts and makes your understanding of acute liver failure better. Thank you for watching.